So I have a question for you. Here's a quiz. Ready? What is the number one youth mental health challenge disorder that of youth? What is number one? Anxiety, yes, number one. So how does one differentiate normal anxiety, nervousness, from that kind of crippling anxiety, clinical anxiety? It's a question that parents just grapple with so much. So we are honored today to have Dr. John Piacentini, who is from UCLA, and he is from the Center for Child Anxiety, Resilience, Education, and Support. And the appropriate acronym for that is CARES. And he's going to share with us some evidence-based tools that we can use, that parents can use to make those distinctions. And he's also going to talk a little bit about understanding anxiety-related disorders, all the disorders that kind of come with anxiety, like OCD and others. So welcome, Dr. Piacentini.
I really wish I could be here with you in person, but I am, fortunately or unfortunately, hopefully this will be my last day of what appears to be a mild case of COVID quarantine. And I thought it best to stay home rather than fly up, since I think I caught this at Dallas-Fort Worth last weekend. So, but I really wish I could be there with you. But I'm going to be talking about treatment of child anxiety. And this is work that we've done through our clinic at UCLA and through our CARES Center, which you just heard about. And I have a few disclosures here, nothing that would impact what I'm going to be saying. But very, briefly, I want to spend most of the time talking about what parents can do, what the science says about that, but I do think it's important to provide a little bit of scope. Anxiety is the most common child mental health disorder, 12 to 20% of children, according to the Surgeon General's report. Some estimates are even higher, some a little lower, but it's a significant problem. A recent paper just came out showing that problematic child anxiety increased 29% from 2016 to 2020. That's a huge increase. And that doesn't account for most of the burden of COVID, which we know has increased anxiety probably even higher. So what was a very significant problem is now an extremely significant problem for the youth of our country. Unfortunately, 80% of kids with anxiety disorder are not getting treatment. And this is probably because it's not always recognized, it's thought of being innocuous, but that fares poorly with estimates of youth with other disorders. And according to the Anxiety and Depression Association of America, anxiety imposes a $42 billion burden just in the US alone. That's child and adult. So it's not surprising that just a couple of weeks ago, the US Preventative Task Force now recommends regular anxiety screening for youth ages 8 to 18. And this would be in addition to the already in place depression screening for those aged 12 and higher. So really problematic, although oftentimes unrecognized. We know anxiety has very significant impacts on educational achievement. It interferes with learning, delays in important developmental milestones. Kids that aren't able to go to school, be with friends, engage in social activities, do not have the opportunity to develop these social skills and other developmental milestones necessary for success in later life. Untreated, anxiety can lead to higher rates of depression, suicidality, substance use, and a whole variety of physical disorders. So we need to really try to figure this out. Excuse me. The first thing we need to think about is anxiety versus stress, because kids are stressed, everybody's stressed, you hear about stress. Stress and anxiety are different things. They're often conflated, but stress is a physical and emotional reaction to circumstances that frighten, irritate, confuse, endanger, or excite. Kids get stressed about holidays, they get stressed about their birthdays, they get excited, stressed about going to Six Flags or an amusement park. It really is, stress is really something that engages us, energizes us to deal with an event that might be emotional, be it positive or negative. And stress, importantly, is a normal part of childhood. And one issue is that stress can be overpathologized. Kids do get stressed, they get excited, they get nervous, and we need to think about that and try to distinguish that from problematic anxiety or stress, which I'm going to talk about in a minute. There are a lot of negative stresses that kids are dealing with now. Gen Z stressors. This came out a couple years ago, but if you look at the mental health of kids born between 1995 and 2010, only 45% report that they believe they're in good or excellent mental health. Less than half of this entire generation. And this is in comparison to other generations that have much higher rates. So we're actually going in the wrong direction in terms of raising and developing healthy youth. So why might some of these Gen Z kids being so stressed? Well, if you look at the news, and again, this is from about 3 or 4 years ago, what's in the news? Mass shootings, rise in suicide rates, climate change and global warming, separation and deportation of immigrants, widespread sexual harassment and assault reports. These are all things that disproportionately impact the young people in our country. And it's no wonder that they're worried about these. Now we have COVID on top of this. So I think you can multiply all of these numbers pretty significantly. So we do have a crisis here in terms of our kids worrying, being frightened, being scared about the future. And we need to fix that. How can we help kids manage stress? Well, there are a number of factors that we can do. Teaching what stress is and how it feels, differentiating stress from fear or anxiety or other factors, normalizing the kids' experiences, modeling our own stress management. You know, that makes me feel pretty stressed too. When I feel that way, I do some deep breathing or I think about positive events. Or let's see if we can come up with a plan to help you get through this or manage the situation that's making you stressed. Certainly for younger kids, limiting exposure to stressful events, discussions, TV, social media. There's another crisis that's brewing with our youth, and that is looking to social media for information on mental health. There are tens to even hundreds of thousands of social media influencers on TikTok and Instagram that are demonstrating a variety of mental health symptoms or syndromes. Tourette's probably most prominent right now. Exaggerating symptoms, making up symptoms, and really and drawing in viewers. There have been over 4 billion viewers of Tourette-related social media, and our kids are looking at this media and they're picking up these symptoms. They want to be like the influencers, and they're ending up in emergency rooms and hospitals. And we're seeing this also with bipolar disorder, with cutting. There's a lot going on. So we need to really understand what our kids are watching, what they're seeing, what they're doing, so that we can help provide them right information and supporting the environment to withstand some of these very intense influences. Routines are very important. Reminding kids of past successes in stressful situations and keeping things in perspective. Interestingly, surveys, when you ask kids what they do to manage stress, they rarely talk to their parents. Yet in those same surveys, 75% of kids in one recent survey reported they want and need their parents' help in times of trouble. So it's up to parents to reach out to kids to recognize and offer support in whatever way is going to work best for their child. So let's talk about anxiety. Short-term episodes of anxiety are normal. I mean, I got anxious giving book reports, going on a big roller coaster, meeting new people. These are all pretty normal things, and they're typically associated with circumscribed events. And they're typically overshadowed by the fact that, well, I was afraid of going on the roller coaster, but I went with my friends and it was a blast. I did my oral report and kids clapped and I got an A. I met that new kid and I was really nervous, but now we're friends. So usually the anxiety is more anticipatory anxiety, and that often melts away because the situation or event that the kids anticipated being negative weren't. Rarely require professional intervention. So how can we determine when our kids need help, when anxiety becomes more problematic? The things we're looking at are intensity of anxiety. Is it out of proportion to the event? Is the child starting to tantrum or get really upset? Is anxiety or avoidance, request to avoid, occurring more frequently? Is anxiety manifesting in response to innocuous threats, things that the child may have been able to do before? Is it spontaneous? Do kids all of a sudden start becoming panicky or really upset for no observable reason? These might be evidence of problematic anxiety and worth talking to the child about. I'm going to talk about how to do that in a minute. When does anxiety rise to the level of potentially needing professional help or some other kind of an intervention? When the child's anxiety leads to avoidance, if the child is starting to miss school, miss social opportunities, other fun activities, family events, that can become a sign that they might need help. Interference with these activities, the child's no longer able to do the things that they need to do, but they're not able to do. Excessive distress, crying, tantruming, withdrawal, and the duration. If a child is nervous or upset by something, oftentimes if it's normative anxiety, it will go away. If the child stays anxious for longer periods of time, that's a sign that there may be some problems there. So I'm going to talk about parenting, but I think it's important to understand the evidence-based treatments for anxiety because we want to really work from parents teaching parents basically these same skills. So let's see what that looks like. When we think of anxiety, along three channels. And I'm going to play a little video for you right now, a very short video that's going to demonstrate this to you.
Think of anxiety as a cycle of thoughts, feelings, and behaviors. A child has a thought or a worry. Maybe people at school think I'm stupid. That thought causes a physical symptom, like a stomachache. Stomachache causes a behavior, maybe crying. Then the crying leads to another thought, which is, oh no, now I look really stupid and I don't feel good. And that thought intensifies the physical symptoms like headache and stomachache. All of this can lead to more efforts to get away from school or avoid going in the first place. It's a vicious cycle.
So we think of anxiety, thoughts, feelings, and behaviors, and we can put these together in a spiral. And those of you that work with depression, you know the depressive spiral. The worse I feel, the less I do, and the less I do, the worse I feel. And it goes down and down. Kids have thoughts, they're frightening thoughts. People aren't going to like me. This dog is going to bite me. I'm going to get kidnapped. Kids are going to laugh at my book report, whatever it might be. Those thoughts lead to physical reactions, the stress response, and that leads to avoidance or crying or tantruming. And then the more the kids avoid, the worse that they get. These thoughts get stronger, the physical reactions get stronger as well. So in treatment, cognitive behavior therapy, we focus on addressing these physical reactions, the stress responses, the sweating, the being nervous, the shaking, using relaxation training, mindfulness, for example. Cognitive coping, we want to identify these thoughts, the negative thoughts. The kids are going to laugh at me. The dog is going to bite me. I'm going to get kidnapped. And we want to have strategies for helping these kids learn that these are anxious thoughts, that they're not accurate. And then to address the avoidance, which is the big problem, we do something called behavioral exposure that I'm going to talk about. Reward systems and lots of family involvement that we're going to hear about in a second. The first step is psychoeducation. We need to talk to our kids and parents about why we're going to do what we're doing. And we usually talk about it from an ethologic perspective. Anxiety has been conserved as an evolutionary trait because it's protective. It's nature's car alarm. The anxiety response is triggered when we believe that there is some kind of danger or fear or threat. For kids with anxiety, by definition, that threat is not actually dangerous. So the goal of treatment then is, from the cognitive perspective, is when the car alarm goes off, you have two thoughts. Somebody's car is being stolen and that's annoying, go deactivate it. So when the child's anxiety response triggers, there's two options. Something really dangerous is happening, or this is just my anxiety alarm went off. The same way car alarms go off all the time and nobody's trying to steal the car. I'm going to use my techniques and try to get through this. So exposure is the most important component of treatment, changing behavior with exposure. And basically it's facing fears in a graded or gradual step. We are literally teaching the kids how to more accurately interpret these threat cues or these anxious triggers so that they can understand that they may not be dangerous at all or as dangerous as they think. So we start from easiest to most difficult and practice and repeat. And it's not about making the fear disappear. It's about learning that the fear isn't realistic or that nothing bad will happen. And we're having a more realistic worldview. So we're teaching the kids to manage these fears of anxiety. Sometimes the anxiety goes away, but you can't really change somebody's thoughts by telling them not to think something. So we really are teaching more management and tolerance of these fears, which do weaken and do disappear a lot of times over the course of treatment. How well does this work? This is from the Child Anxiety Multimodal Treatment Study. It was a 6-site study. UCLA was part of this study. And we treated 488 kids with CBT, as I've described, sertraline, medication, the combination or both. And CBT worked about 60% of the kids got better, medication about 55% of the kids got better, and their combination about 81% of the kids got better. So we have 3 excellent treatments for child anxiety, for families that rather prefer CBT over medication. That we usually start with CBT, and add medication is needed, and the combination in more severe cases does seem to be most effective. And this was borne out both in response rates and in reduction of anxiety. We followed these kids up 9 years later. And what we found is, this is a little bit of a busy slide, but if you look at the blue bars are the total sample. Only 22% of the kids, this study, we followed them from 6 to 9 years. Once a year for 4 years, they got a diagnostic evaluation. Consistent remitters were kids that were anxiety-free at all of these evaluations, only 22%. 48% of the kids had anxiety at some of the visits and non-anxiety at the others, that kind of went back and forth. And over almost 30% of the kids, 28%, had anxiety diagnosis all 4 years. These were chronic kids. So this was pretty disappointing in the fact that our treatments worked great, but they didn't work that great over 4 years. The good news is, if you look at the green bars are kids that responded to treatment in the initial study 6 to 9 years earlier. And what you see here, if you look at the chronic group, kids that responded to treatment initially were much less likely to have chronic anxiety at follow-up. So treatment is protective, even if it doesn't give us the durable gains that we would like to think. The other thing that's a little unfortunate, the kids that relapsed and were chronic, only 20% of them ever reported ever receiving CBT use over follow-up. So almost all of these kids that had anxiety came back, they didn't go back and get more treatment. And only 3% of the relapsers and 6% of chronic youth reported consistent CBT use over time. So the kids that really needed this the most did not stay in treatment, which may explain why some of these rates weren't as high as we would have liked. We also looked at treatment effects at 9 years, so predicting how these kids would be doing. And we found that kids that had responded to treatment at the initial study 6 to 9 years earlier, regardless of whether it was medication or CBT, had reduced risk for chronic anxiety, like I just said, reduced risk for persistent depression and suicidality, better global functioning, decreased overall impairment, and increased life satisfaction. Remission predicted mostly the same thing. And most importantly for CBT, kids who received CBT 6 to 9 years earlier compared to those who received pill placebo demonstrated improved trajectories pertaining to life satisfaction, overall impairment, and academic functioning. Getting CBT compared to not led to significant increases in happiness and academic achievement. And they also had increasing employment rates. In contrast, the kids that got medication only 9 years earlier did not differ from the placebo group, suggesting that there are specific benefits of early CBT and response to CBT for long-term outcomes, even in the face of kind of waxing and waning anxiety symptoms. So let's get to the parenting piece. And the goal of working with parents of an anxious child is to teach them CBT, and we talk about living the CBT lifestyle, using the techniques that we've taught in treatment to help their kids manage anxiety. Anxiety is a chronic disorder. A lot of kids respond and the anxiety will disappear, they'll achieve remission, but we don't think of anxiety going away completely. Again, it's part of the natural condition. We all have anxiety to some degree. It's protective. It keeps us from doing things that are going to hurt us. So we talk more about a maintenance model. And I think that's true for most disorders now in mental health. Unlike our earlier 20 years ago when we thought we could cure these disorders, we're realizing that a lot of the traits and behaviors and certainly neurobiology underlying these conditions are part of us and part of our condition. And we really are looking at more of monitoring and maintenance of the gains rather than letting the kids respond to treatment and then stopping treatment, you're all better. It's not like setting a broken leg. General concepts for parents, encouraging autonomy and acknowledging when the child is facing their fears. So like exposure, encouraging exposure, rewarding the child's courageous behaviors, supporting the child in developing their own problem solving and coping skills, and most importantly for parents is controlling their own anxiety. So communication strategies toward this latter point, and I'm a parent and I have kids that have anxiety, and even though I know this stuff, I do it still all the time. So hard not to. Don't ask loaded questions. Did you get in trouble at school today? Did you cry during your book report? Was anybody mean to you? Did any strangers follow you home? Non-leading questions. Don't overreact or react with excessive emotion. This kid was mean to me at school. What? We don't want to do that. Express empathy, caring, and validation. Express concern honestly by grounding it in reason. Well, let's think about that. What was it likely that person was really being mean to you or really following you? And don't jump to conclusions or problem solve. We always push to problem solve for our kids and we're depriving them of the opportunity to do so themselves. Why is this difficult for parents to let their kids problem solve and work through some of these issues? Well, because if I let my child or my teen struggle, I might be damaging my child. My child's going to hate me. If I make him go to soccer and he doesn't want to, he's going to hate me. It's just easier for me to do it myself. And this parental overprotection trap, so to speak, what it does, it ends up keeping anxiety fixed in place. The kids never learn how to manage anxiety on their own. They never learn that their fears, I'm afraid that people are going to laugh at me at soccer because I'm going to mess up and I'm horrible at this game. If I let my kid stay home every time he says that, I'm validating his fear. I'm communicating, yeah, you are pretty bad and people are probably going to laugh to you and it's going to be negative. And it really limits their developmental progression. So what can we do? What do we want to avoid and what can we do? Well, what we want to avoid is accommodating the behaviors, giving in to the kids, helping the kids avoid, providing negative attention. We are wired, I think most living creatures of one type or another, we're wired to pay more attention to threat than to positive. So when we see something negative, that's what gets the attention. When we see something positive in our kids, not so much. Avoiding overprotectiveness, intrusiveness, anxious interpretation of events. I had a little stomach ache at school today. Oh my God, are you sick? Let me take your temperature. You better go lie down. No, I just didn't eat my lunch. Tolerance or encouragement of escape or avoidance. So family accommodation is probably the most critical thing that we teach parents or want to work with parents about. Accommodation, again, is giving into the child's anxiety, providing materials for the kids for OCD, washing their clothes, whatever it is, engaging in their rituals. And we know that high rates of family accommodation we find in OCD and anxiety, and they're associated with increased family distress. The scary part of this is a study by Nader Amir showed that families that recognize that the OCD or anxiety is interfering with the child, but I can't stop it. I need to wash his clothes. I need to let him avoid. When they do that, their parents recognize on average that that's probably not the right thing to do. And studies show that can lead to increased levels of depression in family members or caregivers. Parents that refuse to accommodate, no, you have to go to soccer. No, I'm not washing your clothes again. I already did. The research shows that that leads to higher levels of anxiety in caretakers. Basically you're damned if you do and you're damned if you don't. So it's really important for treatment to try to understand this and understand where the parents are coming from and working very closely with them to address these issues. We know that greater family cohesion is associated with better disengagement, reducing the accommodation, and it leads to lower levels of parental distress when accommodating, not accommodating. So more cohesion makes it easier to do the right thing as a parent. Higher levels of family conflict make it more difficult to disengage. The kids are more likely to act out, and it can be more difficult for the parents. It's more distressing for the parents. So we have to address these when we're doing our treatments. What are some general strategies for parents? Managing anxious children, managing kids during the pandemic. Now we have war that's making our kids anxious. It's critical for parents to be consistent, clear expectations. Again, you are going to school, you are going to soccer. If you do these things, it will be great. We can do some positives, but we will really need to avoid accommodating. Consistent routines, especially in the mornings. Any wiggle room, any too much flexibility or lack of structure, and kids can exploit that. And again, because anxiety really pushes kids to do things. But we do need some flexibility so we can give our kids fixed choices. You can get up at 8 or 8:15. You can have cereal or toast. You can watch TV. You can read in bed, or I'll read you a story. Stay calm. We need to be prepared to face our child's anxiety and our own anxiety. We need to be firm and neutral. And we need to reward, praise, and give positive attention for attending school or engaging in these other activities. So our attention is moving toward the positive, toward the successes that we see. And then avoiding accommodation, which should be apparent from all of the above. What about the kids? How can we work the kids? What do we want for the children? Same parallel list, morning and night routines. School arrivals. If the kids are having a hard time going to school or engaging, we can go with them. We can help check them in, but they're going to soccer, they're going to piano lesson, they're going to school, and they're going to stay. And again, in very severe cases, obviously, we want to shape these behaviors. You can't throw a child. We no longer teach kids how to swim by throwing them in the lake, but these are the goals. And we want to do these activities to the ability of the child. Tolerating distress, but I'm anxious, I'm afraid, I don't want to go to soccer, the coach is going to be mean to me. So let's do some tolerating distress and anxiety. We have some techniques. Let's do some deep breathing. Let's do some mindfulness. Let's do some self-talk. What can you tell yourself to help you manage and get through this? And then positive events. So if at school, at soccer, at the birthday party, we want to try to set up environments so that the child has positive things to look forward to. We can try to shape these destinations in ways that aren't going to accommodate the child's anxiety, but provide rewards and support as necessary given the child's current state. So negative reinforcement is really what underlies anxiety. If I am anxious and I don't want to go to school and I have a tantrum and my parents let me stay home, my staying home is negatively reinforced my tantrum. Tantrums are good. Tantrums work. Every time I tantrum, I get to stay home. And if my parents get mad at me and try to push me to go, I'm going to tantrum more. And I'm going to hold out because the last one that hangs on to what they're doing, my tantrum, for example, I'm going to win. So if we rescue the child at the height of the tantrum, the child is tantruming and mom goes, oh, I'm late for work, I need to go. Okay, just stay home. The child remembers the situation at the height of the fear. Oh, that was a close call. I am so afraid. I'm so glad I get to stay home, because they're agitated. They're physiologically aroused. They're highly anxious. They're going to remember that rescue. Prevents habituation. If you go long enough, the child's anxiety is going to go down. And there's no experience of mastery. The child doesn't learn that they're able to actually go to school. If we do exposure, if we have the parent wins and the child goes to school, the child remembers that success allows habituation. If I go to school, it's probably going to be okay. I learned that anxiety is transient. I develop an ability to approach increasingly challenging situations. I have a feeling of mastery, and I'm reinforced for hanging in there. So we really need to reduce the accommodation. I mean, I could do the whole talk on this. Our model, CARES model, ecologic model, is focusing on kind of what we call a whole child, whole environment. So we want to create these CBT lifestyle environments across every environment that the child lives in: school, healthcare, family, social. So we've developed parallel trainings. In addition to our clinical work with kids, we have similar programs for teachers, training teachers and school personnel. We have an online educators course that basically talks all about this. We have trainings for healthcare providers, pediatricians, as well as mental health professionals. And we have a lot of programs for families as well, all teaching the same. Our idea is that the child lives in a seamless environment. This is going to be resiliency building. And when they get up in the morning, the mom is going to engage in this and facilitate this environment. When they walk into school, the school is going to be creating the same environment. It's going to be continuous. When they go to sports, when they go to their pediatrician, when they see relatives, again, it's a seamless bubble to build resilience. That's our goal. We're not there yet, obviously, but I do want to talk about one of the programs that we've developed. I know I have maybe just a couple minutes left, that we've developed through the CARES Center. And this was in partnership with the Partnership for LA Schools. And it's a bilingual school-based family resilience program. And I'm going to show you a little clip here because it's going to be about 2 minutes, and I think it can work. I can do this better than I can. Hold on, let's see. Can you see this?
Dr. Piacentini, we can't hear it. Can you hear me?
You can't hear it?
No.
Okay.
Sorry.
Okay. Well, unfortunately, let's skip this. But we have two tools that we use, and the first is butterfly breath, and I love these tools. These tools are just extremely simple to use, and the video demonstrates families using these together as a family and talking about how easy they are. So butterfly breath is basically tracing a butterfly on your hand, following the arrows. You guys can each do this right now. And as you start with the left or the right, as you trace the first wing, slowly breathe in. As you trace the second wing, slowly exhale. Breathe in, breathe out, focusing on the butterfly. And you can do it, as I said, on the palm of your hand. You can do it on the butterfly. And it is surprisingly effective. And we have families do this together when the kids come home from school. The parents, again, the video, the parents like it. It's very simple to do. It's something very easy for them to do. And it's very low tech. The other thing that I don't have, I took the slide out, is using a feeling thermometer. And I assume you all are familiar with feeling thermometers. It's just a 0 to 100 with, the top quarter is colored red. The second one, next one down is orange. Next one down is yellow, and the bottom is green. And it corresponds to where you're feeling. Red, obviously, is my brain's going to explode. Green is copacetic and calm. And we give these to the parents and the families, and they put them up on the fridge and all over the house. And when the kids get home from school, they rate where they are. A little girl in the video, when she comes home, she goes, "Mommy, I'm at an orange," and the brother goes, "I'm at a yellow." And then we have strategies depending on where you are. If you're a red, obviously, that's kind of emergency. Sit down, let's do some breathing. Let's talk about what's happening with you, other management strategies. Is there some exposure we need to do? Orange would also be mindfulness or breathing or coping strategies. And then green and yellow, rewarding the child for how they're doing. These are both really effective, and they can be used by the whole family. And Fuertos, as I said, is a 6-session program. These are some of the program themes. This was really done mostly with inner city Los Angeles families from some of the most under-resourced schools in the city. We've been doing this in Compton and Boyle Heights. And the families really like the program. They like the support, sharing, accessibility. We really put this in a very understandable way, working with some of the parents to create the vocabulary. It's focused on the children's needs, communication, learning about feelings. And you can see I like everything because I'm learning how to relax with myself and my family. So we're currently building an online version of this course with support from the Nicholas Endowment and the Johnny Carson Foundation. And we're hoping that that will be up on our website in a few months. We also have a course for teachers, Manage Anxiety in the Classroom. And this is, we follow four different trajectories of kids: social anxiety, GAD, separation anxiety, and normative anxiety. And the teachers, the educators go through the course, they see videos of the kids in situations, crisis points, and they need to decide what to do. Basically accommodate or not accommodate. And then they can watch videos of the sequelae of their decisions. This is also online. We're creating a national rollout version of this. And the reason I'm showing this is because it's critically important for parents to work with kids. And that's going to be really, really important. So we have different kinds of tip sheets for teachers and families that they can share. We have forms.
We can share these on the AIM website too.
Oh, great.
Yeah, and also the video that you were unable to show, we can share that too. We'll send that out. All of you that registered.
That'd be wonderful.
Yeah.
I think you'll really like it.
Yeah.
And then we have strategies for communicating among parent and teacher and other kinds of materials.
Thank you.
I am going to stop there. I think I might have gone a minute over. I'm sorry I wasn't following the chat as closely as I should have. But
it was well worth the technology glitches, certainly.
Yeah,
Thank you.
Yeah, and I apologize for that.
Thank you. Let's have a round of applause for, and now he's virtual, he can hear. Yeah, we deeply appreciate that. And thank you so much. I have to mention he comes from my undergrad alma mater, so I'm biased, but we will send out the video links and all of those materials because I think it's so practical and so helpful. Don't you agree? Yes, I'm seeing heads nod. Thank you. And one of the things I want to talk about, we're talking about bridging the gap. He talked about the effectiveness of cognitive behavioral therapy, and we're going to bridge that gap between access to cognitive behavioral therapy. I also want to mention one more thing before we break for lunch. A lot of the skills that Dr. Piacentini was talking about are actually included in the mental health first aid training that we are doing at AIM. So we have monthly trainings in youth mental health first aid for parents, teachers, adults to support youth. So I really encourage you to go to our website and sign up for a course. I'm recognizing some of you in the audience who have been through that training, and it's helpful to practice those skills that he's talking about.